Hello. Hello guys, can you hear me? I think now the audio should be coming. If anybody can hear, please let me know so that we can start the program, the lecture. Hello. Yes, Punk, I can hear myself now. I can hear. So just tell me, there is a lot of delay. Okay, so I think now I am audible. And welcome all guys, and welcome Punk and Raghav and Pratisha and Gamer. So everybody, welcome to the stream, and we'll start right away. So today we'll be again revising and discussing everything about ECG and all everything in detail, and it will take a few 2 or 3 lectures, and in that we'll try to cover whole of the ECG, and it's a very interesting topic. And if you have interest in looking at the minute details in the ECG rhythm, and you'll be surprised that you can pick up so many diseases and so many disorders. It's not just the electrocardiographic or the diseases pertaining to the heart, but you can pick up so many other diseases of other systems: hypothyroidism, hyperthyroidism, hypothermia, hyperthermia, and lot of other diseases. And CVS also you can pick up, and chamber enlargements and COPDs, and there are so many diseases, and everything, most of the things you can pick up on the ECG. And it's interesting that it's such a small rhythm, and in that the whole body's working is manifested in some way or the other. So it is very important that you should know this subject very thoroughly. And there's a little delay in the stream, so I think we'll have to bear with it, because this is our broadband. It's FTTH, but still it is not good. And Swati, welcome. So we will start now. And okay, so if you see in this last line, like, a calm state of mind is the best state of mind, and that is very important. If you have to learn something, and if you have to teach something, we have to be very calm and very focused. And if we are distracted, I won't be able to teach you. If you are distracted, you won't be able to benefit from this time which you're spending here. And I want you all to please keep on commenting in the live chat, and that really gives us positive feedback. And whichever ECG I show you, or whatever I'm saying, if you have any questions, you can just ask in the live chat. I'll be very happy to reply. And for all of you who don't know me, I am Dr. Robert James, and I am MBBS MD in internal medicine, and I've also done fellowship in clinical cardiology and fellowship in echocardiography. I'm a product of Christian Medical College and Hospital, Ludhiana. And so I always like to give regards and credits to people who molded me into what I am, and teachers who taught me. So it's always good to start your day or start your lecture by giving thanks to your teachers. So they are all my teachers in CMC Ludhiana: Dr. Dhanoa, Dr. Anamani, Dr. TM Jason, Dr. Carlton, Dr. P.K. Dandona. They were all gems. They were walking dictionaries of medicine and cardiology. And I have imbibed so much of knowledge from and wisdom from them, knowingly and unknowingly. And that is what it should be, how it should be. Never forget your teachers, and somehow you will realize that slowly the wisdom comes into you. And so in ECGs, there is nothing to learn by heart. Okay. In ECGs, like maths, if you know from 0 to 9 numbers, and if you know that by heart and properly, you understand what 1 is, what 2 is, and what 3 is, then you don't have to by heart any sum. Come what may, whichever sum or mathematical sum, multiplication, division I give you, you will be able to find the answer or calculate it then and there. So ECG is also like that. In ECG, you don't have to memorize everything. You have to know the basics. Your basics have to be very clear. And that is what I try to focus on, and that is what I try to tell you guys, that nothing to by heart it, and not to be scared by all these abnormal rhythms. If we know the normal rhythm and we know the concept of the vectors, ECG is all about electricity, how it is moving from one point to the other in the heart, and that is represented on the ECG. And some more people have joined. Ratnam has joined. Good evening, Ratnam. And where is Saurav Beragi? He had promised that he'll come, and he has not come. Other people have come. Anyway, please message him and tell him sir is missing him. So nothing to learn, memorize or mug up. Okay, so if you know what a P wave is, what a QRS is, what is T is, what the different durations are, and how those waves are formed, then you will definitely know if some abnormality is there, if some block is there, how that part of the heart has to be stimulated, how the electricity will go reach that area via a different path. Okay, and the axis will change, and it is very interesting. So it's like maths. And Dr. Einthoven, he was the pioneers in electrocardiography, and he was given a Nobel Prize also in medicine in 1924, and he discovered and documented so many diseases which were detectable on ECG, and based on his findings we have drawn this Einthoven's triangle. So in this we place different leads, and different leads each lead has a positive pole and a negative pole. Okay, now the real lecture. Okay, Pank, Saurav, welcome. So like lead 1, the positive pole is at on the left arm, and the negative pole is at, I'll just maximize the window for my this thing. I have to buy new specs, guys, and I was surprised today that I couldn't read some of the numbers on the papers, so I put on my specs, and I have to get a new pair of specs. So lead 1 has positive pole at left arm, negative pole at right arm. You have to just memorize this. They won't be very helpful in actual ECG, but you can get an MCQ type of question, like where is the positive pole of lead 1 is at LA, right arm, LL, lower left leg. Okay, so like that. From MCQ point of view, this is important. We should know. It's just one slide. And lead 2 is positive pole is at left leg, and negative pole is at right arm. And lead 3 is positive left leg and negative left arm. Okay, and this will come very handy if we know. We will represent this on a circle, and that's a very useful circle, and I will show you. I always keep on speaking about this circle, and everything you can explain in the ECG based on that circle, and I have modified the circle on my own, and most of the things you will be able to explain, and nothing to by heart it. Then so now you know that every lead has a positive and a negative pole. Then another thing is, whenever the impulse is coming towards the positive pole of any electrode, it will be perceived as a positive upright deflection. Okay, so now you imagine lead 1. So let us say lead 1 is at minus, one second guys. Just a sec, guys. Just a sec. Okay. So lead 1 is at 0 degrees. Okay. So whenever some impulse is going towards lead 1 from the SA node, it will be perceived as a positive upstroke, and that is called the R wave. And whenever that impulse is going away from any lead, let us say lead 1, if it is going away from lead 1, it will be perceived as a negative wave. It is called the S wave. So ECG has a P wave, a QRS complex, and a T wave. I'm sure you know all this, but it is always good to revise because we'll be going to real depth of it after 1 hour, not today, maybe tomorrow or day after. So our basics have to be very clear. We will not rush through all these slides. We will take our time, and you can ask any question in the comments box. I'll be happy to answer. And okay, then okay, so this is the circle. Okay, I call it circle, and I have plotted all different leads in this circle, and you can see lead 1 is at 0 degree. This little bit you have to by heart, and at least for 100 ECGs you have to remember this circle. You have to visualize this circle, and then you think about all the leads, complexes. So when you're holding the ECG like this, lead 1, 2, 3, AVR, AVL, AVR, V1 to V6. So conventionally in an ECG, these are the leads, okay? And your brain should be so trained that at the subconscious level, while you're reading the ECG like this, it is mapping all those electrical complexes which you are seeing, which your eyes are seeing. Automatically, subconsciously, you're plotting it on the circle. And then it is just like it's fun game, and you will be able to see from where the current is starting in the heart. Like you can almost actually see, look inside the heart, and it's exciting to see, discover so many things happening in the heart just by knowing that the current is moving from one point to the other. So lead 1 is at 0 degree positive pole. I'm talking about just the positive poles right now. Okay, lead 1 is at 0 degree and lead 2 is at plus 60 degree. Now remember, all the leads in ECG, they are placed at a multiple of 30 degrees. Okay, all the leads, they are placed at a multiple of 30 degrees. So lead 2 is at 60 degrees. So 30 plus 30 is 60. Lead AVF is at plus 90 degree. 30, 60, 90. Lead AVF is at 90 degree. Lead 3 is at plus 120 degree. Okay, so it's all multiples of 30 degree. 30, 60, 90, 120, 150, 180, like that. Then lead AVL. AVL is at minus 30. Okay, and AVR is at minus 150 degrees. Mind you, the hemisphere above the diameter of the circle is negative, and the hemisphere below the circle, below the diameter, is positive. So when we are saying AVL is at minus 30 degree, we are talking about the positive pole of AVL. Okay, so the positive pole of AVL is at minus 30 degree, and obviously it is a straight line. Okay, so the negative pole of AVL will be where? Saurav, anybody? Please comment in the box, live chat. Where will be the negative pole of AVL, or where will be the negative pole of lead 1? The positive pole, I told you, of lead 1 is at 0 degree. So where should the negative pole be? Now you have to remember, current cannot travel like this. Okay, so current cannot travel like this. It will travel just like this, or from here to here, from positive to negative. So it cannot travel in both the direction. It will travel like this or like this. That will make a R wave or a S wave. So can anybody tell me where is the negative pole of lead 1? Nobody wants to answer? There is a lag, I understand. I can see myself talking in the browser. That is after a delay of 45 seconds. So I'll wait for some more time. If anybody doesn't answer, nobody answers, then I will answer. See, the more number of times you answer, the more synapses in the brain will form, and the same memory will be recoverable at a faster speed, at a faster rate. Okay, very good. So Saurabh says it's at 180 degrees. Very good. So it's a straight line, obviously. Current cannot go like this and like this. It will go like this, like either like this or like this. So lead 1 is 0 degree and negative pole is at 180 degree. So the negative pole of lead 2 will be at minus 120 degrees. Negative pole of ABR will be at plus 30 degree. Okay. So this is very important and you have to remember this. Now, I'll cover a little bit of the clinical side also when we are talking about myocardial infarction and the changes, because it will make more sense. Then there is no need to take a separate class on coronary artery disease. So I'll just cover the signs, symptoms in this. So whenever a patient with acute MI comes to you or patient with coronary artery disease comes to you, now what will be the signs and symptoms? He can have chest pain, throbbing chest pain, jabbing chest pain, lancinating chest pain, or he might feel some heavy weight is on his chest, which is not just letting go of, okay, and that feeling will be that it's crushing him. That feeling will be, that is how the patient will explain कि डॉक्टर साहब एक भार सीगा and it was not going. I started talking in Punjabi after making few lectures in Punjabi. So the patient will say, डॉक्टर साहब एक भार है जो उठ नहीं रहा, and I'm finding it very funny while talking in Hindi. So anyway, and the same pain will radiate to the left neck, left angle of the jaw, and the medial aspect of the left arm. So this is a typical classical anginal pain which is radiating to the medial aspect of the left arm. So that is called angina. And how you will differentiate angina from acute MI pain? Acute MI pain will not subside with sublingual nitrates. So if you give sorbitrate or something sublingual, a pain of angina usually will subside, but a pain of acute MI, it will not subside with just nitroglycerin. You have to do more than that. Okay, that is one thing. And if a patient is having MI, he may be having more severe signs and symptoms. He may be having sweating, vomiting, diaphoresis, and his BP might fluctuate. He might go into shock, or he might have a bradycardia or a tachycardia, or a lot of ectopics or VT or blocks. And it's very interesting to see the different MIs will present with different heart rates. Okay, like anterior MI will usually present with tachycardia. Inferior MI will present with bradycardia and blocks. Anterior MI, lateral wall MIs, they will present with tachyarrhythmias. So VTs are very common in anterior wall MIs. And patients with inferior wall MI, they will come with cardiogenic shock usually, with heart blocks, complete heart blocks, 2:1 block, and all those things. And they will have pump failure more frequently. And in fact, in inferior wall MI, nitrates and vasodilators and morphine and Lasix, which will decrease the preload, they are sort of not advised, and they have to be given with a lot of caution when you have MI, inferior wall MI. So these are some signs and symptoms. And whenever there is nausea, vomiting, hypotension, and some other GI symptoms, so that is a result of vagal stimulation, and that usually occurs in inferior wall MI. So today's lecture I will keep very simple, because all these things have to imbibe in you properly. Otherwise, we'll be just touching the topics and running away to the next topic. It will not be very fruitful, and you'll be forgetting most of the things. So what all can you use ECG for? Now, this is a very important question. What all things can you see in the ECG? Okay. So can anybody tell me? So you see, you can check the heart rate, you can see the rhythm of the heart, you can see determine the axis of the heart, You can diagnose coronary artery disease, you can diagnose endocrine disorders, hypothyroidism, hyperthyroidism, and you can see the effects of various drugs and in toxicities, digitalis toxicity, digitalis effect, all these things you can see. You can see the effect of hyperkalemia, hypokalemia, hypocalcemia, prolonged QT interval in hypocalcemia, tall T waves in hyperkalemia, U waves in hypokalemia. So all these things you can see. Then some autoimmune diseases can present on the ECG. You can have lib and sac endocarditis, MR, you can see MR findings, left atrial dilatation and things like that in SLE. So there are so many diseases. Then in infections, sometimes in dengue fever, you will have AV blocks, first degree AV blocks usually, and it will be very interesting. Like if a patient comes to you and with fever, and you see the ECG and you think, okay, I think you have dengue fever, you should get admitted, and it's nice that you have saved a life. So there are so many things. Then various poisonings, so many poisonings you can detect on ECG. Morphine poisoning, it will present with bradycardia. Sulfos poisoning, aluminum phosphide poisoning, it will present with findings similar to acute MI, hyperacute MI, and they will go in cardiogenic shock and very difficult to save them with sulfos poisoning, aluminum phosphide poisoning. In one study in CMC Vellore was done, in which high dose hydrocortisone was given, 200 milligrams of hydrocortisone 6 hourly, and in sulfos poisoning patients, and they made it, many of them made it, compared to those who did not get or who got just 100 milligrams of hydrocortisone every 8 hourly. So that is something to be kept in mind. If you have a patient with sulfos poisoning, you go very high on steroids, and you can give 200 milligrams every 6 hourly and see the effect, and many a times you will be able to salvage these patients. Then organophosphorus poisoning patients, so they will again present with the bradycardia and blocks. So like this, so your imagination is the limit. Okay, you can detect so many things. Then we come to heart. You can diagnose pericarditis, pericardial effusion, and myocarditis, and VSDs, ASDs, chamber enlargement, dilated cardiomyopathy. So many things you can diagnose on the ECG. But for that, we have to have a little sound knowledge of whole of the subject. Now we come to how to take the ECG. Okay, so anybody can tell me how many leads are there? So there are standard limb leads, lead 1, lead 2, lead 3. Now this is a sequence of the leads placed on the ECG rhythm strip. Lead 1, first lead is lead 1, then lead 2, then lead 3. Okay, after that come augmented limb leads, AVR, AVL, AVF. Okay, then V1 to V6 leads. So in that order they are placed, and we will learn about how to place the different leads, and this is how you place the different leads. So V1 you place in the 4th intercostal space, right to the sternum. V2 left to the sternum, 4th intercostal space. V4 in the 5th intercostal space in the mid clavicular line. V3 between V2 and V4. V5 5th intercostal space, mid axillary line, anterior axillary line, and V6 mid axillary line. Then there are, in certain situations, you will have to take more than these leads. Supposing you are thinking of right ventricular infarction, so right ventricular changes you won't see in these leads. Okay, for that you will have to take ECG on the right side of the chest. So V2R, V3R, V4R, V6R on the right side of the patient, like out here. Sometimes you will be suspecting a posterior wall MI. So in that you will have to take ECG changes on V7, V8, V9, V10 posteriorly on the left side. So that will give you a true picture of the MI, because V1 and V2 will give little idea of right ventricular infarction, because V1 and V2 cover very little area of the right ventricle. Rest of the area of the right ventricle is outside the domain of V1, V2. So this you have to remember. And also remember, when you are thinking of inferior wall MI, look for right ventricular infarction, look for posterior wall changes. Hi Jesse, welcome. Okay. So we are back to this same circle and we'll bypass this. Now we are again into the next step of the ECG lesson. Now see, now you look at this picture. Okay, this is the picture of a pacer. Now who is a pacer? Pacer is somebody or some person who sets the rhythm of the race. Okay, so like in marathons, in long distance races, every second, every inch you cover in a stride is important. Otherwise you will get tired if you cover too much of distance in one stride, and it's a 42-kilometer race and you will not be able to finish it. You will burn yourself. Okay, so you have to know how long a stretch you have to reach in each stride. So that is the work of a pacer. Pacer will set your rhythm and he will tell you should not go slower than this, otherwise you will not reach your personal best. And Saurabh, you remember this. Okay, when you run, so you put the pacer in your watch and lot of programs are there. So when you run, so you should set it like I have to finish 5 kilometers in, let us say, half an hour. And at that moment, like then you start and run with the pacer, with the clicks. There are software, they will give you click, like tick, tick, tick. So it will tell you now you should be stepping this fast to complete your 5 kilometers in 25 minutes or 30 minutes or 20 minutes, whichever target you have set. So that is a work of a pacer. And see now here, this lady is a runner, actual runner who is participating in the race. But there are these seasoned Kenyan runners. They must be better than this athlete lady, but they are the pacers. So they have the idea of milliseconds that they have to make their person, this lady, win the race by setting up easy, comfortable pace by which she can win without getting out of breath. Okay, this is a function of a pacer. This is a very emotional picture and I always show whenever I teach, and I am pacing Eric. This was his first international race. He was 5 years old and all these guys in red t-shirts, they are his competitors. And I was running a full marathon and Eric was running his first 5K at 5 years of age. So I was pacing him and I had to stop my race to help him complete the race. And I had tears in my eyes. It was a very emotional moment that my small kid is running and competing with so many guys. And the camera guy, he focused and he actually took a very close-up snapshot that I'm crying. But that was a very heart-touching moment. So we are sort of pacing each other in this race. And so this is a function of a pacer. And in heart also we have pacers. Okay, so SA node is the pacemaker in the heart. So the most prominent, the most normal, the most dominant pacemaker is SA node. So SA node, then AV node, and then there are fibers, and we'll come to the details of that in a short while. So what are the different complexes? So there is a P wave. P wave denotes atrial depolarization, and QRS denotes ventricular depolarization, and T wave denotes ventricular repolarization. So you have to remember this. Okay, like you shouldn't forget, this is just depolarization. P is atrial depolarization, QRS ventricular depolarization, T is ventricular repolarization. Now you should ask, sir, where is atrial repolarization? You cannot see on a traditional ECG because when atrium is repolarizing, the more bulky left ventricle and also the right ventricle, they are contracting and their electrical voltage is very, very high compared to the atrium, because atrium is very vestigial sort of organ. It has to just contract little bit and pump the blood into the ventricles. So it is not hypertrophic, it is not bulky, there's hardly any muscle in the atrium. Whereas the left ventricle, it is very bulky, and it has, because it has to pump the blood against gravity into your head, into your brain, and again it has to turn into the aorta, pump it into the legs. So it is very strong LV. Even the right ventricle has to pump blood into their lungs, but right ventricle also, again, it has to just pump blood into the lungs. So it is also not very bulky, and it's sort of considered a vestigial organ from ECG point of view, because whenever we say QRS, and we say it is because of ventricular depolarization, so it is formed by the electrical activity of the left ventricle and the right ventricle. Okay, it is not like in V1, V2, V2 you will just see the right ventricular electrical depolarizations, and in V5, V6 you will see left ventricle. It's not like that. So QRS is sum total of the electrical activity of the left ventricle and the right ventricle. So this is a very important take home message. Okay, now this is a very interesting ECG, and this is a normal ECG. So see, whenever I'll show you this circle. Let's see. Okay, so whenever you have to see something, okay, you should look at this circle. This is a very nice circle, and everything is explained in this. And now you see, lead 1 is at 0 degree, lead 2 is at plus 60 degree, SA node. So SA node is out here. Okay, now when SA node fires, it fires into the left atrium and the right atrium. Okay, the impulse spreads into the atrium. Then finally it reaches the AV node, into the bundle of phase. There is a small delay there, and then it goes into the it divides into left bundle branch and the right bundle branch. Then left bundle branch further divides into left anterior fascicle, which lies superolaterally, and left posterior fascicle, which lies inferomedially. Okay, and right bundle branch goes to the right side to supply the right ventricle. So whenever the impulse is coming towards the positive pole of any lead, it will be perceived as upright positive deflection. Okay, now you see, SA has fired and impulse is going directly towards lead 2 when it is going to stimulate the ventricles. Okay, it is directly towards lead 2. So lead 2 is very happy. Okay, a lot of electrical current it is getting, lot of attention it is getting, and so it will make a very nice P wave, very nice R wave, and very nice T wave. Now at this point, another take home message. Remember, note it down. T follows R. These are some observations which I have made over a period of time, over many years. After reading a lot of books, I'll come to that slide, which are my observations, and they will never fail you. And if something is different from those observations, something is wrong in the ECG. Okay, T follows R. If R is of good amplitude, T should be of good amplitude. Okay, and if R is not tall, T will be small. T should be small. For example, like in lead V1, I will show you different ECGs as we proceed. In V1, okay, Jesse, I know this picture I expanded, so that's why it is probably not clear. And I can WhatsApp all the students this picture, and or else through in the class when you guys come on Tuesday or Friday, Monday or Thursday, I will give you this picture. But this circle is something, it is very important. So T wave, okay. So see, SA node has fired and it is going towards left ventricle. SA is fired, it is going towards lead 2. So lead 2 is very happy and it has formed a good P wave, good R wave, and good T wave. Now for AVR, what is happening for AVR? You see, for what is happening for AVR? For AVR, the impulse is always going away from AVR, and for AVR it is always going away. Now see out here, SA has fired, the impulse is going away from AVR. So AVR will draw all negative impulses, negative P, negative QRS and negative T. Okay, another take home message. All the impulses in AVR have to be inverted. If some complex is upright, something is wrong. If P wave is upright in AVR, some abnormal pacemaker is pacing the heart. Maybe the AV node is firing upwards to stimulate the atrium, in which case the impulse will be going towards AVR while stimulating the atrium, and you will get a positive P wave in AVR. Okay, so AVR is the most neglected lead, and most of the people, doctors, they will not give too much importance to AVR. But in AVR you will get wealth of information. So if AVR's P wave is upright, it is probably a junctional beat, a junctional tachycardia, a junctional rhythm, or junctional bradycardia, or junctional escape beat, something like that. Okay, and if ST is elevated or T is upright in AVR, it is a sign of a very grave situation in the myocardium. Either the patient has had a very bad inferior wall MI, usually inferior wall MI, or the patient has had right ventricular infarction or a lateral wall MI. So nothing has to be upright in AVR and nothing has to be coving in AVR. Everything has to be inverted, because the impulse is always going away from AVR. When the SA fires, it is going towards lead 2. So AVR is unhappy, it is drawing all negative impulses. Okay, so this is the importance of AVR. Now I have also drawn V1 out here, V2 out here, V3, V4, V5 is at the tip of the apex, LV apex, and V6 is little away from V5. Now R wave is tallest in V5 in a normal ECG, and V6R is also good, but it is slightly smaller than the R wave of V5. Okay, so you just remember this, and it is very important. And from V1 to V6, R waves, they will keep on progressing slowly. In V1 there will be very small R. Okay, I have to show you the okay. In now see, now imagine the SA node has fired. Okay, so SA node has fired and it is going, impulse is going like this. So lead 2 draws a very good P, R and T. Also at this point you have to know that there are different types of QRS complexes. There will be RS complex, like out here there is a R wave and a S wave, small S wave, RS complex. This is also RS complex. There R is small, S is deep. This is just R complex because the impulse has to start from SA node and it has to reach till the LV. It cannot go beyond the LV. Okay, so no S wave should be formed in lead 2. In lead 2 everything is very, very positive because the impulse is coming directly towards lead 2. Okay, so nothing negative in lead 2. Remember this. In lead 3, so now again you see in this circle, lead 3 is out here. Okay, for some time it feels happy that impulse is coming towards lead 3, positive pole. Then it goes away to stimulate the left ventricle, and in that case when it is going away to stimulate the left ventricle for lead 3, it is going away. You have to use little bit of imagination, and then a small S wave will be formed in lead 3. But for lead 2 everything is positive. Just remember this. For AVR everything is inverted. That's the most important part. And okay, so this I have shown you. So this we have discussed. Whenever we have to look for right ventricular infarction, we have to take ECG rhythms on the right, ECG leads on the right side, V2R, V3R, V4R, V6R, like that. Okay, if there is ST elevation in, if the ST is elevated in V4R, so more than 1 millimeters, so that is a very grave sign. Okay, so now we come to the calibration. So after this we will stop, because otherwise you will be overloaded with a lot of teachings. So, but nevertheless, this is the most important lesson of this lecture today. What is calibration? So calibration is whenever you take an ECG, you will note that the ECG machine makes a deflection like this just before all the complexes. Okay, Jesse, we'll try to make it, but yeah. So now see in this. So this is calibration. Okay, calibration is the machine calibrates and tells you how high the impulse will go, and that will reciprocate with the R wave amplitude. Now out here it has to be 10 small squares in height, then a horizontal plateau and a vertical fall. So that is a normal calibration. Now in the first one, the calibration is just 5 small squares, and in that case, let us say you are given one ECG with this first calibration, this one with just 5 small square height. So that means if supposing in that ECG V5 shows R wave amplitude of 20 small squares, 20 small squares, then, and this is 5 small squares, so it means we have to calculate for 10 small squares height calibration. So 20 into 240, so 40 small square height R wave amplitude. That is very severe hypertrophy of left ventricle. Okay, maybe his patient has hypertrophic obstructive cardiomyopathy. So this is how your diagnosis will change to a very grave disease. So calibration is very important. And on the other hand, if the calibration is going up and then it is a downward slope plateau and a down vertical fall, it can form a false R wave, and even when the patient is having MI, it will show a R wave. So that is so it is important, this calibration. Okay, then you see, supposing there is upstroke 10 small squares and then upslope horizontal plateau, where horizontal plateau has to be there. It is upstroke and downstroke. It can form a false S wave or a Q wave. So that is why this is very important. Okay, calibration. So calibration you should always ask for, and because sometimes the QRS complexes is very small and calibration is 5, but if you add double the QRS complexes height or depth, it will be in the normal range. Now this also I will just cover this about the ECG paper. Now ECG paper has small squares and big squares. Okay, there are 5 small squares in one big square, and one small square duration is 0.04 second horizontally and 0.1 millivolt vertically. So in the vertical axis, in the y axis, we calculate the electrical voltage like this. Okay, like this is the duration of any complex or any interval. So this is very important. So one big square will be how many seconds or milliseconds? Can anybody tell me? Saurav, your call. One small square is 0.04 seconds, and one big square will be how many seconds or milliseconds? Anybody else can also answer? So you have to just calculate. So one big square has 5 small squares. One small square is 0.04 seconds. 0.04 into 5, 0.20 seconds. Okay, so how many big squares will make 1 second? This is very important, because to calculate the heart rate, it is very easy. 300 divided by number of big squares, or 1500 divided by number of small squares between 2 RR intervals. That is very easy. But when it comes to atrial fibrillation, where RR interval is irregular, there you have to calculate it for 1 second or 10 seconds and multiply by 60 or 10, and that will be for 1 minute. Okay, so that's how you have to calculate the heart rate in atrial fibrillation. Yes, good. So it's 0.20 seconds. And so one big square is 0.04 into 5, that is 0.2 seconds, and 0.2 into 5 is 1 second. Okay, so you calculate the number of RRs in 1 second, or you calculate for 10 seconds. If you're calculating for 10 seconds the number of R waves in 10-second duration, you multiply by 10 6 is 60. Okay, so that will be the heart rate in atrial fibrillation. So that is how you calculate the heart rate in atrial fibrillation. So guys, I think we'll stop here for today, and because otherwise it will not be very fruitful if we just keep on covering the slides and we are saturated. And so thank you for joining, and thank you everybody, and all of you guys, like, you're great, and come for the next class also. Tomorrow will be more fun, same time 7 p.m. and we'll discuss more. So today, just to recapitulate, calibration, and in fact you can ask your teacher, sir, please provide me the calibration, so that it will enable me to answer correctly whatever MCQ you have asked or whatever spot you have put. Okay, without calibration it is very difficult to give a concrete answer. And there are lead 1 2 3, AVR, AVL, AVF, V1 to V6, and T follows R, and lead 2 has the most positive complexes, and good P, good R wave, or R wave sounds a little funny, so we always will be talking about good QRS complex, good T wave. But when we are saying QRS complex in lead 2, we are meaning R wave only, because there is no S wave, because current cannot go anywhere else after the myocardium is over. Okay, and for AVR everything is inverted, because current is always going away from AVR. So AVR will show a negative P, negative QRS, negative T. And if something is upright in AVR, supposing there is a positive P wave, that is junctional rhythm or junctional bradycardia or junctional tachycardia, that is sending one signal above towards the AVR to stimulate the atrium. Okay, and rest of the rhythm will be occurring normally through bundle of phase, through LBB, through left bundle branch and right bundle branch. Okay, so that's the basic what we discussed today, and tomorrow we'll continue. And please subscribe and like and comment and share on your Facebook also these lectures, and I need more audience, and please invite all your friends from other medical colleges also, and that will be very nice if there are a lot of people in the live streams, and it makes our day. So thank you everybody, and thank you for coming, and God bless. Stay happy. Bye bye. I'll be online for 5 or 10 minutes, and if you have any queries, I'll be available to answer. means it will be a good idea to get a book and start taking notes, and you can review these videos again and keep jotting down the points. And in the end, it will be a very beautiful journey for you all.